Margarita, Chris, and Phil, we've been through a day and a half of remarkable lectures, a lot of fundamental work linking inflammation to cardiovascular disease. We went to the insulin signaling pathway. This is getting more and more complicated, remarkable breakthrough there. But still, even though this is a complicated field, I think now if we start with inflammation, we have solid evidence that inflammation is linked to cardiovascular disease, and we begin to understand why it is the case. Marceau, on your side.
I think that, you know, the evidence we have been facing in this meeting has been absolutely very convincing and outstanding, and of course opening up of new links at the molecular level has been really fascinating to find the association between the different insulin signaling pathways and, you know, once again the consequences leading to the inflammation. I think it's very important. Of course, considering the clinical practice, I think that one key issue over there is that how do we follow up the inflammation, and of course we have some good surrogate markers like the sensitive CRP and so on, which clinicians can be using, but still I think that we should just recognize that inflammation is part of the cardiometabolic risk, and then we have the simple measurements as you have always proposed, that is the waist measurement, and also, you know, what's linked with a high risk over there, of course, is measurement of plasma triglycerides.
Chris, you have contributed to that field. This whole issue of adipose tissue also playing an important role in that link between inflammation and cardiovascular disease, right?
So yeah, I think it's, if we were to take a lot of science and put it into simple terms for clinicians and patients, the concept of either adiposopathy, cardiologists talk about cardiomyopathy, but adipose tissue doesn't function well, and you sick adipose tissue, and you push these concepts, keeps it in the mind of the patient that where really it goes back to this whole issue of the waist. And I say, where did you gain your weight in the last 20 years? It's always the same thing for the men, at least, skinny arms and legs, and that's affecting not only what we saw in regards to the high blood sugars and the lipid problems, which they never understand triglycerides, but that also when we get these tests like C-reactive protein, now we can give another motivation for lifestyle modification and weight loss. And the data, we'll be presenting some data soon, but the impact on in the look-ahead study was at least as great as that of a statin seen in the Jupiter study for lowering CRP.
Phil, as a scientist, as the head of a large heart institute in Australia, you frequently have to talk to the press about, you know, the drivers of risk right now. In the context of inflammation, what are your key messages to them?
I think that we've actually made huge progress over the last few years, and this meeting has brought together basic science, clinical medicine, and public health issues. But I think three really important messages that are not just for clinicians but for the general public. One is we are really beginning, we've known for a long time that abdominal obesity is linked to type 2 diabetes, is linked to cardiovascular disease. What we now know is that one of the key players in this link is inflammation, and it's inflammation originating from the abdominal fat. Knowing that means that we now have even more of an imperative to manage that and to reduce the abdominal fat. But what we've also heard is what is driving the abdominal fat. It's a combination of both a lifestyle and a genetic. We can't change the genes, but we can change our lifestyle. And what we've heard today, and I think supported by many recent studies, is that if we reduce the amount that we eat and increase our physical activity, we can make a difference, make a real difference. But the most exciting thing that I heard was that physical activity has benefits even if there is no weight loss, both in terms of controlling diabetes, preventing progression to diabetes, and almost certainly reducing cardiovascular risk. So this has been a fantastic meeting, and it's brought all of these things together.
Speaking now of lifestyle, I'd like you to reflect now. You are scientists, but you are clinicians. You know, we also heard this issue that maybe the low-fat diet message, you know, which was the message that was conveyed, you know, to the press. You want to lose weight, low fat. That it was essentially wrong. It's much more the quality of the diet that matters.
I think this was very exciting information that we received concerning the different diets, you know, how little differences there really are considering the end outcome. That means, you know, weight loss between the different kind of diets which you can use for that. I think that the best message, of course, is that eat less and move more. Mm-hmm. And that is very simple. Instead of paying too much attention how many grams of fat I'm eating and what kind of fat is that.
Because for the patient it could be extremely confusing. You know, you have those low fat products out there that are loaded with sugar, and at the end of the day the caloric intake is not substantially reduced. But for patient, maybe just a few nuggets point, fruits and vegetable, you know, food oriented approach. I don't know what's your experience, Chris.
Well, I think the other thing that comes out was actually some of the data you showed that the compliance is one of the key things. So it's, the issue of is that when you work with your patients is you give them a goal which includes weight, you give them an exercise goal, and then you set up some follow-up mechanisms. And your study I thought was quite nice, once a month, where they were meeting with a dietitian and someone talking about exercise. Quite an impressive 3-year benefit for this. So I think this is one of the things that the biggest problem is that rather than focusing on the type of the diet, is if we were to set up a better plan for compliance, that they're meeting with a dietitian, they're talking about exercise, they're getting weighed and discussing where their problems are, why I got out of it, and the motivational part, we might be more successful. And that will require, even though you're at a very reasonable price, unfortunately, a lot of the patients don't want to pay anything in regards to lifestyle modification because insurance won't cover it.
Phil, in closing, you know, again, you have been through those years. You know, you have seen the evolving risk factor, the change in the landscape of risk factors. What's the next step now? We know from an individual standpoint, we're getting some hints of what we need to do in terms of reshaping physical activity and nutritional habits, but there's a big public health challenge out there. Your views on that in closing?
It's the huge challenge of the 21st century. We've almost won our battle against cholesterol. We've almost won our battle against blood pressure. We are winning in many parts of the world our battle against smoking. We have not yet begun to win our battle against obesity, especially abdominal obesity. We cannot rely on drugs to correct that. Even if there were drugs that were safe, they would bankrupt most countries. It has to be lifestyle, and it has to be a combination of healthy eating habits, sensible eating habits, not losing 5 kilograms next week, aiming at losing weight slowly that can be sustained for life, and maintaining physical activity at a level that is compatible with that person's life. That's the challenge. If we don't win it, we're going to have, for the first time in many generations, the next generation will not live as long as their parents. And that's a huge concern.